Academy YouTube channel. And we please ask you to interact with us. Dr. Anderson is here to answer all of your questions. So please type your questions during this masterclass on our Q&A chat box, and we are going to be happy to answer during the discussion in the end of the session. So we are very happy to continue to have Dr. Anderson with us at least for 2 more months. So we have planned all of these next classrooms for all of you, and I'm sure all of us are going to learn a lot from Dr. Anderson. And just remind you that on the 10th of November, we are going to have a very interesting masterclass with Dr. Gil Vernovsky. He's going to talk about fragility, anti-fragility, and resilience in the pediatric cardiac care. So this is going to be a very special session addressing not that much technical issues on our job, but other skills that we have to have. So please join us on this webinar as well. So now we are happy to have Dr. Anderson with us. Please enjoy and learn with us, guys.
Good afternoon to you, ladies and gentlemen. Today we are switching tracks, and we're going to discuss malformations of the atrioventricular valves. And we're going to start off with a discussion of EBSTEIN'S malformation. So, of course, if we're talking about EBSTEIN'S malformation, we should know a little bit about Wilhelm Epstein. So as you see, he was born in the early part of the 19th century in what was then Prussia. He was educated at Breslau, which at the time was part of the Prussian Empire. Nowadays it is Wrocław, or my Polish pronunciation is very bad, but that is now part of Poland. He completed his education in Berlin, but then he returned to what was then Breslau in 1861 as a physician. And it was whilst he was working in Breslau that he made the discoveries that we now remember in his name. But he didn't stay there for very long. In 1874, he was appointed as professor of medicine in Göttingen, probably the foremost of the German universities, and he remained in Göttingen for the remainder of his career, dying in 1912. But it's arguable that we should be calling Epstein's malformation Presche's malformation, because it was the heart of Joseph Prescher which stimulated Epstein to make his descriptions. So Joseph was 19 years old, and he was admitted to the hospital in Breslau, where Epstein was the physician, in 1864. He complained of shortness of breath, he had a rapid heartbeat, and he had suffered with those symptoms since childhood. When he was examined, he had a big heart. He was also blue, and the heart was full of noises. But sadly, having been admitted into the hospital at the end of June, within a few days, he had died because, as you all know, at that stage, there was little that could be done for these congenital cardiac malformations. But having sadly passed away, Epstein was responsible for coordinating the autopsy. The drawings of the heart of Joseph Prescher were made by Dr. Weiss, and this is one of his drawings. In fact, I've reorientated the heart to make it more or less attitudinally appropriate. When Epstein made and published the original drawing, the apex of the heart was pointing downwards. But what I'm going to be discussing with you today is one of the important things, which is to discuss the heart as you see it in the patient, and increasingly now as you see it in techniques such as cardiac magnetic resonance imaging or computed tomography. So I've turned the image by 90 degrees So you see now the apex of the heart pointing to my right hand to the left of the patient. And you see that within the right atrioventricular junction, and to make this drawing, Ebstein has opened the heart and has turned open the flaps of the right atrioventricular junction. And there on the septum, we see a remnant of the septal leaflet. Ebstein's original description has been translated many times, and this remnant that you see on the surface of the heart has variously been described in these translations as the size of a nickel, or the size of a dime, or the size of a quarter. And I rather fancy that this relates to inflation rather than to the original size, because when Ebstein described it, he described it as the size of a dry groschen, a threepenny piece, which we remember in the threepenny opera. I'm not sure of the precise size of the dry groschen at the time of Ebstein, but there we see the remnant in his drawing. Significantly, you see that Ebstein shows a tongue of tissue between the inferior leaflet of the tricuspid valve and the anterosuperior leaflet of the valve. And that, as I was also described to you, is an important feature of the heart we now name in honor of Wilhelm Ebstein. Another key feature is that the orifice within the valve has rotated through 90 degrees. And it is no longer pointing towards the apex of the ventricle, but instead it is pointing into the infundibulum. And it's what I'm going to call the keyhole. And if we look at the second drawing that Ebstein made of the heart of Joseph Prescher, you see this time he has opened the outflow tract of the right ventricle. To the top of the image, you see the three leaflets of the pulmonary valve. And there now very nicely, you see this rotated opening within the leaflets of the tricuspid valve. So there to your right hand, you see the remnant of the septal leaflet. And there are apical attachments of the abnormal anterosuperior leaflet. And the attachments of these abnormal leaflets across the apical part of the trabecular part of the right ventricle mean that the remaining valvular orifice is now functioning in bifoliate fashion. And this is another important feature that I'm going to emphasize as we look at modern day pictures of Ebstein's malformation. So if you are to understand the differences between this abnormal arrangement, then we of course need to compare those abnormalities with what is going on in the normal tricuspid valve. But then we need to take note that no two cases of Ebstein's malformation are alike. So the other thing I'm going to emphasize is that having noted the differences between the tricuspid valve in Ebstein's malformation and what we see in the normal heart, we then need to analyze the changes we find in the setting of the phenotypic feature of Ebstein's malformation, which is apical displacement of the septal and inferior leaflets away from the atrioventricular junction. But let me start by revising with you the anatomy of the normal tricuspid valve. And to do that, we need to take note of what is going on in the atrioventricular junctions. And you are all now aware that there are two such junctions in the normal heart. And what we have now discussed on several occasions is that in normal heart, these junctions are separated one from the other by what we call the atrioventricular separating structures. The junctions then are different in the right and left ventricles. And this is also important to the understanding of Ebstein's malformation. When we look at the junction in the right ventricle, it is almost exclusively muscular. The junction obviously supports the leaflets of the tricuspid valve, but another key function of the tissues of the right atrioventricular junction is that they interpose between the atrial myocardium, ventricular myocardium at all points except the penetration of the atrioventricular conduction axis. So that is another key function of the right atrioventricular junction. So here I'm showing you a 4-chamber cut through a normal heart. I've concentrated on the junctions, and there you see the right atrioventricular junction, the left atrioventricular junction. And between the two, we have the separating atrioventricular structures. Now, I also want you to take note of what you see to your left hand, because the parietal right atrioventricular junction, which as you see contains the right coronary artery. I'm going to discuss that in the setting of the valve very shortly, but it's also full of fat or adipose tissue. And it is that fibroadipose tissue, for the larger part, that produces the insulation, which is part and parcel of the function of the right atrioventricular junction. When we look at it in short axis, we will note that it has the shape of a D. And the straight side of the D is adjacent to the ventricular septum. The other key point of the right atrioventricular junction when compared to the left atrioventricular junction is that on the right side, the atrioventricular junction is separated from the ventricular arterial junction, which supports the pulmonary valve. And as I hope you all know, the tissue interposed between the atrioventricular and ventricular arterial junctions is what we call the supraventricular crest. Now, I've already emphasized for you the presence of that fibroadipose tissue within the right atrioventricular junction, because although much is written about an annulus, in fact, there is very little fibrous tissue that supports the hinges of the tricuspid valve, and it is fibroadipose tissue, for the most part, that produces the essential insulation between the atrial and ventricular myocardial masses. So if, like me as an anatomist, you stand in the atrial chambers and you look down on the base of the ventricular mass, you get a picture that looks like this. So now the left-sided structures are to your left hand, the right-sided structures are to your right hand. And so to your right hand, you see the right atrioventricular junction. To your left hand, left atrioventricular junction. And between the two, the separating atrioventricular structures. And you see that I've pictured those in the form of a triangle with its apex pointing upwards. So let's enlarge the area of the right atrioventricular junction. And we find that at the apex, that triangular component of the separating structures, we find the membranous septum. And then the triangle itself represents the atrioventricular muscular sandwich. And there is fibroadipose tissue within this sandwich forming the tissues of the inferior pyramidal space. Now, when we position the heart on its apex, as EBSTEIN did when initially drawing the heart of Joseph Pressure, the apex of this triangle points to the right. But in reality, when the heart is in attitudinally appropriate position, as you see here, the apex points upwards. And that is an important point to bear in mind. But we are concerned with the D-shaped configuration of the right atrioventricular junction. And the straight arm of the D is supporting the septal leaflet of the tricuspid valve, the circular part, the anterosuperior, and then here is the key point, the third leaflet, the tricuspid valve, when we view it in attitudinally appropriate fashion, is inferiorly located. Now, those of you who are echocardiographers do not look at the atrioventricular junctions from the atrial aspect in most instances, as I do as a morphologist. You see them in this fashion. And now the right side of the heart is to your left hand, the left side to your right hand, and I've labeled the tricuspid and mitral valves. Note that the diaphragmatic surface of the heart is horizontal. And this, of course, is inferiorly located. And this is the key to attitudinal nomenclature. So let's blow up the tricuspid valve again and look at it in attitudinally appropriate fashion. And now beautifully, you see that the largest leaflet is indeed positioned antero-superiorly. The second leaflet lies against the septum. This, in fact, is the most posterior leaflet of the tricuspid valve, because posterior is to your right hand. So the third leaflet, which up to now many people call the posterior leaflet, in reality is the inferior leaflet because it lies along the inferior surface of the ventricular mass. Now, when you are doing echocardiography, oftentimes you cut sub-oblique costal cuts. And this is what the tricuspid valve looks like when you take an oblique subcostal cut through the ventricular mass. Because now you also cut through the aortic root, because the aortic root interposes between the leaflets of the mitral valve and the septum, whereas the leaflets of the tricuspid valve hug the septum. And that's why my good friend Richard Van Praagh points out that the tricuspid valve is septophilic, it loves the septum. The mitral valve is septophobic, it hates the septum. Note, at the back we see the coronary sinus, and our cut has gone through the right ventricular inlet. Now, a key point here, because the inferior part of the muscular ventricular septum separates the right ventricular inlet not from the left ventricular inlet, but from the left ventricular outlet. And this is because the aortic root interposes between the mitral valve and the septum. So there at the base of the aortic root, we see the membranous part of the septum. Now, if I blow up that membranous part of the septum, here in a heart where I've cut away the non-coronary leaflet of the aortic valve so that I can show you the non-coronary aortic valvar sinus, there is the membranous septum. And in most instances, it is crossed by the attachment of the septal leaflet of the tricuspid valve, dividing it into a part that is atrioventricular and a part that is interventricular. This arrangement is never seen in the setting of EBSTEIN'S malformation because the hinge of the septal leaflet is displaced apically. So all of the membranous septum in the setting of EBSTEIN'S malformation is an atrioventricular structure. But the other important part of the membranous septum is that penetrating through the atrioventricular component to reach the interventricular component is the conduction axis. So there you see the hinge of the septal leaflet of the tricuspid valve. I'm showing you to your left hand the atrioventricular part of the septum, to your right hand the interventricular part. And you'll see that in this particular heart, the interventricular part of the membranous septum is occupied by the branching atrioventricular conduction axis. There it is, sandwiched between the atrioventricular part of the septum and the crest of the muscular septum, and descending down the left ventricular septal surface, we have the left bundle branch. And this relationship between the membranous septum, the crest of the ventricular septum, is retained in the setting of EBSTEIN'S malformation. So we need to know the precise location of the atrioventricular conduction axis. And I can show you in this dissection where, again, now I'm looking down on the base of the ventricular mass from above. So to your left hand now, you see the mitral valve. But in this particular dissection, I have removed the non-coronary aortic valvar sinus. And now you see this inferoseptal recess where the aortic root interposes between the mitral valve of the septum. And now on the rightward border of that inferoseptal recess, you see the muscular sandwich, which is the part of the atrioventricular separating structures, and cranially you see the membranous septum. And between the two is the location of the atrioventricular conduction axis. And this holds good in the setting of Ebstein's malformation. So if the surgeon is able to identify the apex of the triangle of Koch, the membranous septum, then he or she knows that that is where the atrioventricular conduction axis will be positioned. The other key component of the right atrioventricular junction, I've already emphasized, is the right coronary artery. And in 9/10 of individuals, the right coronary artery is dominant, as you see in this dissection. And when the right coronary artery is dominant, it encircles the anterosuperior and the inferior leaflets of the tricuspid valve. And then it gives off two key arteries. In over half of cases, it gives rise to the artery, the sinus node. Whenever it is dominant, it gives rise to the artery, to the atrioventricular node. So this right coronary artery also remains a potentially dangerous entity in the setting of Ebstein's malformation, because it will retain its location at the atrioventricular junction. So before we look specifically at Ebstein's malformation, let me relate these features of the atrioventricular valves to the way they function. So the mitral valve, which has aortic mural leaflets, closes in bifoliate fashion. Because of that, there is a solitary zone of apposition between the two leaflets of the mitral valve. The tricuspid valve in the normal heart, in contrast, closes in trifoliate fashion. And it is the loss, in most instances, of this trifoliate function of tricuspid valve that is part of the essence of understanding Ebstein's malformation. This is the arrangement as you see in an autopsied specimen. We can now see exactly the same thing using virtual dissection. I've shown you virtual dissections before. For the most part, they are produced by my good friend and colleague, Shumpei Mori, previously from Kobe, now working in Los Angeles. And this is one of Shumpei's beautiful depictions of the atrioventricular junctions as seen from the apex of the ventricles. And in Shumpei's picture, again, very nicely, you see the mitral valve that will close in bifoliate fashion, the tricuspid valve that will close in trifoliate fashion when the valve is normal. And that is the key to understanding. So if I summarize what I've told you about the normal arrangement, the right atrioventricular junction is largely muscular, and supported within that right atrioventricular junction, you have the leaflets of the tricuspid valve. And they are positioned septally, anterosuperiorly, and remember, when viewed in attitudinally appropriate fashion, the third leaflet of the tricuspid valve is inferiorly located and hugs the wall of the diaphragmatic surface of the right atrioventricular junction. So we can also call it the mural leaflet. And then remember, when the valve is functioning normally, it functions as a trifoliate structure. So let's return to the heart of Joseph Brescia, because on the basis of what I've just told you, you can see the key difference between the majority of cases of Ebstein's malformation and the normal tricuspid valve. Because as Ebstein himself showed in the heart of Joseph Brescia, the septal leaflet met against one of the edges of the abnormal anterosuperior and inferior leaflets, giving us a bifoliate manner of closure of the valve such that there is a solitary zone of apposition now between the component parts. And it is appreciating how the valve becomes distorted so as to produce that bifoliate arrangement that permits us to the understanding of the malformed valve. So if we are to approach the anatomy of the malformed valve, again, we need to think of structure versus function, remembering that now the valve is going to function in bifoliate fashion. I'm going to mention the relationship to valvar dysplasia, because in the greater majority of cases, the valve in the setting of Ebstein's malformation is not only abnormal in terms of its position, it is also abnormal in terms of the dysplasia of its leaflets. I shall say a few words at the end about segmental combinations. And I must remind you not to forget the associated malformations, although I won't be saying a lot about these associated malformations. Instead, I'm going to concentrate on the anatomy of the malformed valve. So the phenotypic feature that gives us Ebstein's malformation is abnormal hinging of the septal and inferior leaflets. And you see that beautifully in the picture I am now showing you. Again, you are looking down on the base of the ventricular mass from the atrial aspect. So the left side of the heart is now to your left hand. Sternocostal surface is to your right hand. And to make this picture, I've opened the right atrioventricular junction and I've spread it so that you can look down towards the apex of the right ventricle. And you see that I've labeled for you the anterosuperior leaflet, what remains of the inferior leaflet, and the septal leaflet. And now you see the key difference between Ebstein's malformation and the normal heart. Note in passing that as in the heart of Joseph Pressure, there is a tongue of leaflet tissue that joins together the remnant of the septal leaflet of the valve and the inferior leaflet. But there is the valvar orifice. And now you see that because of the abnormal hinging, the valvar orifice is no longer at the atrioventricular junction. And this then is the phenotypic feature. It is displacement of the hinges, septal, and the inferior leaflet away from the atrioventricular junction. Because the junction, the point at which the atrial myocardium is separated from the ventricular myocardium by the fibroadipose tissue, retains its normal position. But the key point is that the hinges of the valves rotate away from the atrioventricular junction such that they form a new valvar orifice at the junction, the atrialized inlet with the functional right ventricle. So this is key to understanding the location of the valvar orifice. So Christian Schreiber, very sadly no longer with us, a brilliant young German pediatric cardiac surgeon who very sadly passed away with a wasting disease a couple of years ago. Whilst I was still at the Brompton Hospital, Christian came to London and spent 6 months working with me at the Brompton Hospital. And Christian put together the findings from 23 autopsied hearts with Ebstein's malformation. And here you see the location of the valvar orifice in these 23 hearts. And the key point is that it is rotated away from the atrioventricular junction using the inner curvature, the membranous septum, as its fulcrum. And it is this rotational displacement that is the key to understanding. It is not downward displacement, although that is how you see it echocardiographically. It is only downward displacement when we put the heart on its apex and we describe it in Valentine fashion. When we look at the heart in attitudinally appropriate fashion, it is a rotational displacement. And it is that rotation that is the key to understanding. So here is another heart with EBSTEIN'S malformation, again open so that you're looking at the inlet aspect down towards the apex of the right ventricle. And now you see the consequence of that rotational displacement. The anterosuperior leaflet retains its attachment at the atrioventricular junction, arising from the atrioventricular aspect of the supraventricular crest. But you see that in this particular heart, there is obvious conjunction between the septal and the inferior leaflets. Most importantly, they are rotated away from the atrioventricular junction. And there now, in this particular heart, the valve has formed a new orifice at the junction between the inlet, and we call that the atrialized inlet because now it is looking at atrial pressures. The valve now is bifoliate, as in the case of yosic pressure, and it closes in bifoliate fashion. So here is the outlet of that particular heart, and to me, the similarity between this picture and the illustration that Wilhelm Epstein made of the heart of yosic pressure is striking, because you see that the orifice, the newly formed orifice, this bifoliate orifice of the tricuspid valve, is now pointing directly into the subpulmonary infundibulum. And that is very important for you as echocardiographers, because if you take a 4-chamber cut through the heart, in many instances, you don't see the leaflets. And this gives you the impression that there is unguarding of the right atrioventricular junction. And to an extent, that is correct, because the leaflet tissue is no longer hinged at the atrioventricular junction. But instead, when we look at the other half of the heart, and so this is the anterior part of that particular heart. Again, now you're looking at it from behind. You're looking towards the apex of the right ventricle. So you see the left ventricle to your left hand. You see the right ventricle to your right hand. And now in this heart, as in the one I showed you a moment ago, the leaflets have been rotated away, but they are forming a new orifice at the junction between the atrialized inlet and the functional right ventricle. And you see that the orifice is much narrowed compared to what we would find in the normal heart. But it's not always like that. So the major variation that we find in the setting of EBSTEIN'S malformation depends exclusively, or not exclusively, but for the larger part, on the attachments of the anterosuperior leaflet. So in a number of cases, you will see an arrangement like this. And this is what I call focal attachment, because in these examples, the anterosuperior leaflet has retained its focal attachments towards the medial papillary muscle of the septum and the anterior papillary muscle at the apex of the right ventricle. And so there you see the anterosuperior leaflet. At the septal end, it's supported by the medial papillary muscle, and towards the apex of the ventricle, along with the inferior leaflet, it is supported by the anterior papillary muscle of the right ventricle. But we do see the phenotypic features. So both the inferior leaflet and the septal leaflet are displaced away from the septum in rotational fashion. And if you look only at the septal leaflet, again, you will see the comparison with the heart of yosic pressure. It is a small remnant attached on the septal surface. Nowadays, the surgeons correcting this lesion, we'll want to separate these leaflets from the ventricular mass and rotate them back to the atrioventricular junction. And this is the essence of what we now call the cone repair, originally done by Dr. Da Silva when he was in Brazil. He's now working in Pittsburgh, and he should take great credit for appreciating that you can liberate the leaflets, tricuspid valve, and move them back to the atrioventricular junction. But this is not always possible. So it's key to appreciate these differences in the attachments of the anterosuperior leaflet. So here I'm showing you focal attachment, which is at one end of a spectrum. So let me take you through the spectrum of malformation of attachment of the anterosuperior leaflet. So here is a very nice example in which the orifice is quite large, but it is still rotated so that it is looking towards the subpulmonary infundibulum. The feature of this heart, however, is the extensive tongue that connects the anterosuperior leaflet, in this instance, with both the septal and the inferior leaflet. But when we look at its distal attachments, you see there are spaces along the way. And this is what we call the hyphenated attachment. And there is a spectrum whereby those spaces are closed. So here is the next stage of that septum. And now, as in the heart of Joseph pressure, there is linear attachment of the conjoined anterosuperior and inferior leaflets. And this is at the apex of the right ventricle, separating the right ventricle into the atrialized inlet and the functional right ventricle, which is made up of the apical trabecular and the outlet component. And now in this heart, you see how the keyhole orifice is between the margin of the conjoined anterosuperior leaflet and the remnant of the septal leaflet. If we turn ourselves around and we look down on it from the inlet, so there you see the keyhole from the inlet aspect. And now I am showing you the extent of this atrialized inlet component. And in most instances, the walls of this inlet component are thinned. And that is what we call anatomic atrialization, in contrast to physiologic atrialization, which is the fact that because of the rotation of the leaflets, always the inlet is going to be looking at atrial pressures. So in this, there we see the atrialized inlet component, one of the features of EBSTEIN'S malformation. But if we continue the spectrum, we see that the keyhole can be closed, as you see in this instance, and that is now giving us an imperforate EBSTEIN'S malformation. So this now is tricuspid atresia, but it's not typical tricuspid atresia. It is tricuspid atresia due to an imperforate tricuspid valve. And now, if we turn the heart around, we see the functional right ventricle, which has an apical trabecular component, an outlet component supporting the pulmonary trunk. And when the tricuspid valve is imperforate, the blood reaching the functional right ventricle must come through a ventricular septal defect. So this is one of the associated malformations, because it is also possible to have a ventricular septal defect in the other variants of EBSTEIN'S malformation. It doesn't have to be an imperfect valve. So the key to the ability for the surgeon to liberate those malformed leaflets, to turn them into a cone, and to let the surgeon reposition that cone at the level of the atrioventricular junction is primarily what is happening to the anterosuperior leaflet. And what I've shown you is a spectrum of malformation, starting with the focal attachment, moving through hyphenations, till we have the linear attachment, as was present in the original heart of Joseph pressure, and on occasion, an imperforate valve. And I think it makes more sense to look at this as a spectrum rather than artificially to divide these into types A through D. I can't remember where the steps in this progression take place. To me, description is much better than seeking alphanumeric categorizations. Those who are operating on these hearts must then remember the atrioventricular conduction axis, and the landmarks remain the same, although they may be harder to recognize. So the atrioventricular node is towards the apex of the triangle. Cork, the inferior pyramidal space, retains its normal position. Another key surgeon will be the right coronary artery, which again retains its location within the right atrioventricular junction. But part and parcel of EBSTEIN'S malformation is dilation of the right atrioventricular junction. And when performing the cone procedure, the surgeon will also try to restore the atrioventricular junction to its normal dimensions. So there, another key feature is not to obstruct the right coronary artery. Now, let's not forget the associated malformations. I've already mentioned ventricular septal defect. We can have EBSTEIN'S malformation in setting of an atrioventricular septal defect with a common atrioventricular valve. And this image, as with so many images made by Diane Spicer, a beautiful 4-chamber cut, shows you an atrioventricular septal defect with EBSTEIN'S malformation of the right component of a common atrioventricular valve. I also mentioned dysplasia. In most instances, the leaflets in the setting of EBSTEIN'S malformation are themselves dysplastic. But dysplasia does not always mean EBSTEIN'S malformation. So I'm showing you here a heart with severe dysplasia of the leaflets, but the leaflets here are normally attached at the atrioventricular junction. So this heart is exhibiting tricuspid valvar dysplasia, but is not showing EBSTEIN'S malformation. The two are discrete entities, but almost always in EBSTEIN'S malformation, the leaflets are additionally dysplastic. I've also mentioned the importance of segmental variations, because thus far I've only spoken about EBSTEIN'S malformation in the setting of concordant atrioventricular connections. There is a comparable lesion in many instances in the setting of congenitally corrected transposition. And the phenotypic feature of that lesion, of course, is discordant atrioventricular connections. And so in that setting, when there is usual atrial arrangement, the tricuspid valve is left-sided, and it is the left atrioventricular valve that is abnormal. So in the patient with congenitally corrected transposition, this lesion can seem to be the mitral valve, but of course it is the morphologically tricuspid valve. But very rarely there can be an ebstenoid malformation of the morphologically mitral valve, and then it is the mural leaflet rather than the septal leaflet that is involved. But let me just say a few words about the ebstenoid malformation in the setting of congenitally corrected transposition, because we now know it is not typical EBSTEIN'S malformation. This is showing you a picture of the left morphologically tricuspid valve in an example of congenitally corrected transposition, and there you see the hinge line of the septal leaflet. And as in regular EBSTEIN'S malformation, it is rotated away from the level of the atrioventricular junction. But a key difference between the ebstenoid malformation and EBSTEIN'S malformation as seen in the setting of concordant atrioventricular connections is the fact that it is rare in congenitally corrected transposition to find anatomic thinning of the ventricular inlet portion. There is, of course, physiologic atrialization, because this will be looking at atrial pressures, but if you compare the thickness of the inlet in this heart with the thickness of the myocardium of the functional ventricle, you see there is very little difference between them. And this is the key difference between the EBSTEIN'oid malformation we see in congenitally corrected transposition and the features of Ebstein's malformation in the setting of concordant atrioventricular connections. There are, of course, other malformations. An atrial septal defect is particularly frequent. And in time gone by, the surgical treatment of Ebstein's malformation was closure of the atrial septal defect. A ventricular septal defect can make the situation even more complex, and there can be pulmonary stenosis. In the setting of pulmonary atresia with intact ventricular septum, there can be a degree of Ebstein's malformation, but it is not full-blown Ebstein's malformation in many instances, and that is why, again, many would not call this pure Ebstein's malformation, but certainly the lesions are related one to the other. And then we must remember that in several instances in Ebstein's malformation, we find abnormalities of conduction, in particular Wolff-Parkinson-White syndrome, and almost certainly that relates to the fact that the right atrioventricular junction is itself abnormal, so there are additional muscular connections crossing the abnormal junction. So if I put all of that together, if we are to understand the anatomy of Ebstein's malformation, we must appreciate that the phenotypic feature is the malformation of the septal and inferior leaflets. They are away from the atrioventricular junction, but the displacement is rotational rather than downward. And because of that, the valvar leaflets are hinged now at a junction between the atrialized inlet and the functional right ventricle made up of the apical trabecula and the outlet components. For those of you who are assessing patients for surgical correction, you must look at those attachments of the abnormal anterosuperior leaflet and its relationship between the inferior and the septal leaflets, because nowadays the surgeons are going to want to liberate these leaflets from the ventricular muscular to turn them into a cone of valvar tissue and to reattach that cone at the level of the atrioventricular junction. Remember also that in the setting of congenitally corrected transposition, oftentimes we have an EBSTEIN'oid lesion, and do not forget the associated malformations. But if you put all of that together, then you will have a full understanding of Ebstein's malformation.
Thank you very much, Dr. Anderson. This was an amazing session. Thank you very much. And we missed Dr. Silverman today. He has another commitment, and for sure we miss him here with us. But we still have time for a couple of questions. To start with, I have one personal question. What is the explanation of the myocardium of the inlet portion to be that thin, as we don't see this on the EBSTEIN'oid?
It's a very good question. I'm not sure I know the answer to that one. It's strange to me. I have seen a couple of hearts in congenitally corrected transposition where the inlet has been thinned, and there's no obvious reason why it shouldn't be thinned. I guess it must have something to do with the original thickness of the myocardium and the remodeling anyway. But I say that off the top of my head. I have no evidence whatsoever to say. I don't know the answer to your question.
Okay, but thanks for trying. Maybe we should try to do some research on that, because this is very interesting. Anyway, and we have a couple of questions here on the Q&A box. Guys, if you have more questions, please type there. So one of the last things that you told us, Dr. Anderson, was about the different stages of the tricuspid valve and how it relates with the surgical procedure. So there's a question from Sandeep asking, are correctable by the cone repair?
Again, that's it's a very good question. I'm not sure that I think you have to analyze each case on its own merits, because my understanding, and Sasha can perhaps answer this better than I, the surgeon has to look at what he is confronted with, and he has to see whether it's feasible to liberate those valvar remnants and put them together so that you can make a cone of tissue that will then be reattached at the level of the atrioventricular junction and will close in regularly normal fashion. So much will do with, as I concentrated on the attachment of the anterosuperior leaflet, because the anterosuperior leaflet is attached on its ventricular side. There are lots of myocardial connections that tether it. The Mayo Clinic have done a colossal amount of work with EBSTEIN'S malformation. My late lamented friend Gordon Danielson operated on hundreds of these in his career. Joe Delaney now is probably the master, along with Da Silva, on the operations for EBSTEIN'S malformation. And the Mayo people concentrate on what they call that tethering on the ventricular aspect. So I guess this is something, Sasha, you need to tell me if I'm right here, but this perhaps is something that the surgeon does not immediately see when you open the heart from the atrial aspect, but when you detach the leaflets, you would see all those tetherings, would you not? And you would have to judge the ability to liberate that anterosuperior leaflet, look at the remnant of the inferior leaflet. Is there anything left of the septal leaflet? Can you liberate these from the ventricular walls, put them all together, create the cone, and then bring the cone back to the atrioventricular junction? Is that a reasonable thing, Sasha?
Yes, I think that you talk, your experience is like a surgeon, so you really explain in a perfect way. I want to underline only one point that I think is the main point of the discussion. EBSTEIN operate during neonatal period. It's a very challenging patient for the top surgeon of the world, but I'm sure we learn a lot from referral center like Mayo Clinic. And of course, as you say, when the child is grow up, so it's very different to evaluate all the types of anomalies that you describe. Probably, as you say, the best way to describe a disease to describe by literature, not by a vocal. So I think that the message you sent is very clear for most of the people. I think that, again, neonatal EBSTEIN is a very nightmare. And cone operation also, we learn a lot from the guy, from the people from Pittsburgh. Now the Brazilian colleagues works in Pittsburgh. And when we have this, the meeting also them, they say that only for very symptomatic patient is considerable to make a correction. But I think that cone is a fantastic procedure, not in the mean for all hands in neonates, but we learn a lot from pediatric patients. And now, of course, case by case, we can adapt to neonates. But I think that the best way to describe the EBSTEIN is what you did with the 4-type description of the position of the valve, because this is, again, the main point.
I agree with you 100% about the neonatal type, because one of the big problems with neonatal EBSTEIN is that it's been present throughout gestation, and then you have the problem of the wall-to-wall heart. And then not only do you have the problem of the valve is friable, the tissues are not well formed, but you also have the fact that the lungs are squeezed out. So Grace, for you as an intensivist, the fact that the lungs are also screwed up must be horrendous when you're dealing with neonatal EBSTEIN. You're muted.
When I have a very symptomatic EBSTEIN patient, there's a lot of features that we have to deal with, and one of them is the size of the lungs, the hypoplasia of the compressed lungs. We have some questions that is very interesting. More than one person asked about the character, if is there a morphological explanation for Wolff-Parkinson-White syndrome on EBSTEIN'S anomaly?
I think there has to be, and I think it is all to do. Though I noticed, I was checking the questions, there was also the question about the embryologic development. And one of the things about the embryologic development is that the valves delaminate from the cushions that are present during initial development. And in fact, the inlet of the right ventricle is very small in comparison to the apical trabecular component. And then often after the end of the embryonic period, in fact, even at the end of the embryonic period, and we do that through Carnegie stages 9 to 23 for development of the heart. Even at Carnegie stage 23, there is very little formation of the inferior and the septal leaflets of the valves. So they delaminate from the walls subsequently. And so EBSTEIN'S malformation is a failure of that delamination. And the hinges of the valves stay at the margins where the cushions are before they begin to delaminate. And of course, it is the delamination that then brings the hinges up to the level of what is the atrioventricular junction. Because during the early stages of development, the cushions lie within the inlet part of the ventricle, and then the atrioventricular junction is produced where it ought to be. So I guess the fact that the cushions are not delaminating also means that there are abnormalities in the separation of the atrial and the ventricular myocardial masses at the level of the atrioventricular junction. And that is why we get the persisting bundles that are responsible for giving us EBSTEIN'S malformation. We still don't know the precise mechanisms of separation of the atrial and the ventricular muscle masses. That's something that we still need to work on. But almost certainly it is the fact that the valve, the cushions are not properly delaminated that must impact on the formation of what's going on at the right atrioventricular junction.
Thank you. And Dr. Luciana, who helped to develop the cone procedure, is here with us today. And
is it not?
Now we have the very specialist. Hi, Luciana.
Hi, good morning. It's always nice to talk with you.
Please comment on that. You were commenting something on the chat box. Can you tell it?
Yes, I think it's important to freeze that, to reinforce the idea that the cone procedure can be done in some patients in neonatal period, but it can also be done after the EBSTEIN'S procedure in that very sick one, in the very displaced leaflets. As Dr. Anderson said, the leaflets are very friable, very fragile, and then we should avoid to do the cone in the neonatal period, but we can still do in some special situations. And if you have experience with that. So, but later in life, after the EBSTEIN'S, we have done some cases after the EBSTEIN'S procedure. So if the kid is very sick when he is a newborn, is preferable to do the EBSTEIN'S procedure, especially in the circular shunt, when we close the pulmonary valve, and then later in life, we can do the valvoplasty in the pulmonary valve and the cone procedure in the tricuspid valve. Thank you.
Thank
Are
you.
you in Luciana?
Thank you, Luciano. The point is that sometimes surgeons believe that they can start with cone in neonatal case. And as you say during your experience, is not such an easy management, not only for surgeon, but also for the ICU. So as you say, probably EBSTEIN'S is the first stage for sick neonates, doesn't preclude the opportunity to arrive to a fantastic, to a perfect cone.
Yes, with the biventricular repair later in life. This is a new idea that we started last year, and we have now more experience with that. And of course, not all the patients need the stance procedure initially. Like I talked in my presentation, some of them we can manage clinically, some of them need the stent in the PDA, some of them just need the closure of the PDA and wait. And so I put on that fluxogram. I think it's a very important fluxogram. We are following this fluxogram here, and it's working perfectly. So it's a special situation, and I think we need to teach, not to teach, but to alert everyone that it's there is a great variability of presentation and management for those patients. We will do a symposium about EBSTEIN'S anomaly here in February, and I would like to have Dr. Bob Anderson joining us. I still didn't talk with him, but I hope he can join us in this EBSTEIN'S anomaly symposium that will be at the end of February next year. Thank you.
Will that be a virtual symposium, Luciana, or is that going to be a real symposium?
It will be a mixed symposium. We will be here in the Rangus Auditorium, but we will have international participants online. So it will be up to you if you want to come here to visit us. It will be a great pleasure. But if you cannot, online will be a great contribution also, as usual.
Well, as you will remember, Luciana, I should have been in Pittsburgh this October, but sadly, COVID got in the way. But if it is, as you know, I always enjoy being in Pittsburgh, so it would be my pleasure to be with you, but I will certainly be with you virtually, but even better to be with you if possible. But who knows what is going to have happened with COVID by then.
Yes, it was always a great privilege for Pittsburgh team to have you here. And I know your important work with Dr. Zuberbühler here describing the EBSTEIN'S anomaly late in the beginning of the Pittsburgh experience. So it's a great contribution that you have done to EBSTEIN'S malformation. Thank you.
Well, it's very nice to see you there in Pittsburgh. And in fact, you probably know that the hearts that I showed today are all still in the basement of your hospital, because they were all wonderful pictures that I took together with Zuberbühler during my period in Pittsburgh, which was wonderful for me. I have very fond memories of Pittsburgh, and it's great that you and your husband are now there. And how is Victor?
Victor now is in the OR. I'm here in the OR also. He's doing a double switch operation in a congenital corrected transposition of great arteries at this moment.
Okay, well, give him my very best wishes. And I'm sorry I've not been with you in Pittsburgh this year.
We are missing you a lot. Thank you.
Thank
Bye.
you.
Thank you, Lou. Thank you very much.
It's amazing what we can do now through Zoom. You can hook us up instantly with Pittsburgh. Yeah. It is fantastic.
We just saw Luciana typing on the chat box. And said, no, you're going to say come. And she's amazing. And we miss her in Brazil for sure. And we have one last question from Dr. Ahmad Salehuddin, who is our surgeon here in Doha. As you just mentioned about the lamination of the tricuspid valve, he's asking why the mitral valve is spared in this disease, why it only happens on the left, on the tricuspid valve.
Now that is also a very interesting question, because as I say, very rarely you can have EBSTEIN'S malformation of the mitral valve. I have seen 2 cases during my career of EBSTEIN'S malformation of the mitral valve. And then the point I made, it is the mural leaflet of the mitral valve that is then involved, because on the left side, it is the mural leaflet that delaminates away from the septal surface. Now, a very good question as to why the valve should be so frequently involved on the right side as opposed to the left side. In fact, there is very little mural leaflet of the mitral valve when first formed, whereas on the right side, the septal leaflet and the inferior leaflet are much more extensive. So I'm sure that must have something to do with it. So I guess there's much more chance for things to go wrong on the right side than there is on the left side. But that is an excellent question. And these really are the questions we don't know the answers to at the moment. There might be genetic reasons. I mean, as we look into the genetics of Ebstein's malformation, the genetics of the formation of the mitral valve versus the tricuspid valve. Very good question. There are many questions that still remain to be answered. So do not think that we have solved everything about anatomy as yet. We still have so much to learn.
This is true. Well, it was an amazing session. I have to thank all of you for attending today. And please tell your colleagues that this was a very nice